Chapter 7 looks at opioid analgesics. Let's first start by covering the mechanism of action of opioids. When you think about these drugs, they're going to work on several different receptors. That could include mu and kappa and delta. Of course, the mu receptor is probably the most important for our purposes because that's where most of our drugs are going to work. Mu receptors are GI coupled, and those mu receptors are found both presynaptically and postsynaptically. But importantly, because they're GI coupled receptors, you can begin to explain the inhibitory actions of opioids on pain. Let's start with the presynaptic receptors. When you stimulate a presynaptic opioid receptor, that receptor is going to cause a decrease in calcium influx. And when I close those calcium channels presynaptically, I inhibit the release of a neurotransmitter. In this case, the transmitter is substance P. Substance P is one of our pain transmitters, so this first mechanism reminds us one of the ways that opioids can stop pain, they inhibit the release of an important pain transmitter. The second mechanism, opioid receptors are found postsynaptically. When I stimulate postsynaptic GI-coupled receptors, I get an increase in potassium efflux that causes membrane hyperpolarization. When I hyperpolarize the membrane, I'm going to prevent the propagation of the pain signal. If you put those two mechanisms together, it says that opioids stop pain by decreasing the release of a pain transmitter and by decreasing pain transmission. If I think about other receptors that work similar to this, what are some other presynaptic GI-coupled receptors that we've discussed before? Well, you might remember those MAD2s. M2, alpha-2, and D2 are all presynaptic autoreceptors that decrease neurotransmitter release. What's an example of a postsynaptic receptor that is GI-coupled? Well, perhaps you're also thinking now about M2 receptors, but on the heart. M2s on the heart, they're coupled to potassium efflux, they cause membrane hyperpolarization, and they slow the heart down. So we've seen similar examples from previous lectures. Let's review the properties of morphine since it is the prototype of the opioids. Its properties are going to be very, very similar to the other opioids. So morphine has an analgesic effect, can increase your pain tolerance and decrease perception and reaction to pain. All opioids are CNS depressants, so clearly they're going to have a sedative effect. But on overdose, how does that CNS depression manifest? It shows up as respiratory depression. This is what's most often fatal on opioid overdose. Opioids are going to decrease your response to increased CO2. You can't simply give these patients oxygen. The antidote is naloxone. By blocking the mu receptor, you can quickly reduce or overcome the action of the opioids, thereby decreasing the effect on respiration. Generally, we expect very few cardiovascular effects from opioids, but morphine has the ability to cause vasodilation. That's because morphine can cause histamine release. Histamine can vasodilate. Many times this is through a nitric oxide pathway. This is why you need to watch out for morphine in head trauma. Because of the vasodilating effect, you can see an increase in intracranial pressure. You definitely want to focus on the smooth muscle effects of opioids. We're not as concerned as much about what these drugs do to longitudinal smooth muscle, which is to cause that muscle to relax. Rather, look at what opioids do to circular smooth muscle, causing constriction. Opioids are going to decrease peristalsis. In fact, watch out for the side effect of constipation. Probably this is the most classic group of drugs that we have for causing constipation. If I think about other important drugs that we've covered that might also cause constipation, well, perhaps you're thinking about muscarinic antagonists. Atropine-like drugs decrease GI motility, so constipation is a side effect. You might also remember the calcium channel blocker verapamil. These are all drugs that can cause constipation. Not only do we see a decrease in GI motility with opioids, we see a decrease in urinary motility causing urinary retention. In the biliary tract, we see an increase in biliary pressure, sometimes described as biliary colic. Can lead to gallbladder spasms. So this type of abdominal pain can be part of the profile for opioids. Finally, watch out for pinpoint pupils. You expect opioids to cause meiosis. Opioids have a cough-suppressing effect. We refer to this as an antitussive action. The most popular of the opioids for this purpose is, of course, codeine. This happens independent of analgesia and independent of any respiratory depression. Opioids can directly stimulate the chemoreceptor trigger zone. That can lead to nausea and vomiting. It's interesting that opioids can cause vomiting because at the same time they actually can have an antiemetic effect. Because opioids inhibit pain, and pain is a stimulus for nausea and vomiting, that's a reason why an opioid could actually have an antiemetic effect. When we consider the metabolism of morphine, it's metabolized by glucuronidation. That's not surprising because a lot of drugs are metabolized by this phase 2 reaction. What is surprising is that almost always glucuronidation is a way to inactivate drugs, but not in the case of morphine. Morphine 6-glucuronide is highly active, in fact, more active than the parent drug morphine. So the unusual thing here is that glucuronidation forms a highly active metabolite. When you look in the margin at the clinical correlate, there are several contraindications and cautions for opioids. The most important of these we've already covered. That would be to watch out for morphine in head injuries. Due to its vasodilating action from histamine, you can see an increase in intracranial pressure. Let's highlight one more. There's a contraindication in pulmonary dysfunction, unless you're dealing with pulmonary edema where opioids actually have benefit. This is related to their ability to cause respiratory depression, so you don't want to use these drugs in somebody who already has a pulmonary dysfunction. Our table looks at the various opioids and their properties. We divide the drugs into a few different categories, starting with the full mu agonists. When you look at the drug meperidine, let's just pause right there and say meperidine is the opioid that's different from the other full agonists. The reason why meperidine is different from many of the other opioids is because this drug blocks muscarinic receptors. By blocking muscarinic receptors, it is the opioid that does not give you meiosis. In fact, it's more likely to cause mydriasis. Most of your opioids have minimal effects on cardiovascular function, but if they do, they tend to be more cardiodepressant. Meperidine is a cardiostimulant. Its antimuscarinic effect can lead to tachycardia. But blocking muscarinic receptors gives this drug different or opposite effects on smooth muscle. You don't get spasms of the GI tract, the urinary tract, or the gallbladder with meperidine. So you're not going to see the biliary colic with this drug like we did for other opioids. Meperidine is metabolized by P450 enzymes to normeperidine. This metabolite works like an SSRI, and that's why meperidine could contribute to causing serotonin syndrome if it's ever combined with another serotonin drug like an SSRI, or like TCAs or MAOIs, which also can increase the levels of serotonin. That can result in serotonin syndrome. Next, we have the drug methadone. The long-acting opioid methadone has been used in the maintenance of opiate addicts. We take advantage of the long half-life of this drug, and we use it as a way to slowly taper the addict off of the opioid. It's a way to control them over time. Codeine, also a full agonist, is worth noting as a popular cough suppressant, a very important analgesic. Many times that is combined with NSAIDs or acetaminophen. Perhaps a minor point, but maybe not, is that codeine is a prodrug. That means P450 enzymes have to convert this drug to its active form, which happens to be morphine. Think about this as the opposite scenario to what we learned earlier for P450 inhibitors and P450 inducers. A P450 inducer would convert codeine to its active form more rapidly, whereas a P450 inhibitor would prevent the activation of this drug to its active metabolite. That is totally the opposite of the rule that we learned way back in general principles. Maybe that's what's worth remembering as well. Next, we have a special group of drugs that are known as partial agonists, and the prototype of this group is buprenorphine. Buprenorphine is a partial mu agonist. You know, when I use this drug by itself, its agonist abilities can be very effective at preventing pain. But it also sets us up for a scenario where if I take a partial agonist like buprenorphine and a full agonist at the same time, I can precipitate withdrawal. Hang on to that thought and let's discuss the next group of drugs, and then we will discuss where the full agonist comes into this story. We have a couple of drugs known as mixed agonist-antagonist, nalbuphine and pentazocine. The reason they're described as mixed, these are drugs that can stimulate kappa receptors, but they block mu receptors. Stimulating kappa can have a very good analgesic effect. Kappa is a great receptor, by the way, so even though these drugs don't work by stimulating mu receptors, they're still very effective at preventing pain. The problem, or perhaps the test question, comes in because these drugs can block mu receptors. That's a problem if the patient is also taking a full mu agonist. A scenario might be your patient is a heroin addict. Heroin is a full mu agonist, a very, very powerful opioid. If they're on heroin and you place that person on buprenorphine, then those two drugs are going to compete. Remember that in the body, a partial agonist acts as an antagonist. But what if it's heroin and you put them on a drug like pentazocine? Pentazocine blocks the mu receptor, and that can block the action of the heroin, precipitating withdrawal. So these three drugs, buprenorphine, nalbuphine, and pentazocine, can precipitate withdrawal if the patient takes them in a full agonist at the same time. So my note reminds us, do not give any of these three drugs to a patient on a full agonist. You get almost immediate withdrawal. Our final category are the antagonists. Naloxone is a very, very popular drug with a short half-life. We can use this drug IV to reverse the respiratory depression associated with opioid overdose. Naltrexone, notice a similar spelled drug, a little bit longer name. This drug has a longer half-life, in fact long enough that we can take this drug orally. This drug can reduce the craving for alcohol and also be useful in opiate addictions, but it's not the drug that you want to use for opiate overdose. The final drug is methyl naltrexone. This is a drug that can treat opioid-induced constipation. The drug doesn't cross the blood-brain barrier, therefore it won't precipitate withdrawal, but it does block the peripheral actions of opioids on mu receptors, and in many cases that can relieve the side effects, including constipation caused by the opioid. Typically, this drug is used as kind of a last resort if the patient fails to respond to laxatives. We should mention the drug Suboxone. Suboxone is a trade name for a combination of buprenorphine plus naloxone. Suboxone clinics have become very, very popular today as a way to manage opiate addicts, and they're considered as an alternative to methadone clinics. Suboxone, being a combination of buprenorphine and naloxone, is taken sublingually. Buprenorphine, the partial agonist, when it's taken sublingual, it's rapidly absorbed into the bloodstream, and its partial agonist effect is going to give the patient some ability to satisfy their craving for opiates. But when you take the drug sublingual, naloxone is ineffective. Naloxone is only going to work if it's given IV. If you're asking, why would I take a combination of drugs, one of which is never going to get into the bloodstream if I take it the right way? Well, the reason why we add naloxone into this preparation is to prevent abuse. Your opiate addict will sometimes get more desperate. They'll want a more rapid high from their opiate, so instead of taking this combination sublingual as prescribed, they could grind this up and inject it. What happens now if you inject the combination? Naloxone is going to block mu receptors, and that can precipitate withdrawal. So instead of getting the feeling that they wanted, they actually get the symptoms of withdrawal. So naloxone is there to prevent abuse. Classic side effects for opioids: pinpoint pupils, depressed respiration, and coma. Manage these individuals with supportive care, and as we've discussed, IV naloxone. It's interesting that you develop tolerance to many of the properties of opioids, but you don't develop tolerance to meiosis or constipation. In fact, your heroin abuser will always be using lots of laxatives because they're always going to be constipated. The withdrawal signs of opioids include yawning, lacrimation, salivation, anxiety, and sweating. When I think about it, if opioids are CNS depressants, what does withdrawal from a CNS depressant look like? It looks very stimulant-like. So some of the properties of opioids remind me of sympathetic activation. So the management of opiate withdrawal can include depressing the sympathetic nervous system. One of the drugs you could use to manage withdrawal symptoms is the drug clonidine. Clonidine is the alpha-2 agonist that works centrally to decrease sympathetic outflow. And that's why this drug can be useful, because a lot of those signs and symptoms of withdrawal are very sympathetic-like. Certainly you could do supportive care for these patients, but methadone clinics or Suboxone clinics can also be useful as a way to slowly taper them off of the opioid over time. We also have some opiates with some very specific indications. The drug loperamide takes advantage of the fact that opioids are going to have a constipating effect, so you can use them to treat diarrhea. Loperamide, in fact, is available over the counter, and the reason this drug is over the counter is because it does not get into the CNS and therefore has no abuse potential. Dextromethorphan, a very popular cough suppressant as well. It, along with codeine, are considered important for its antitussive effects. Now that we've finished this chapter, let's do a few questions together. Here's the first one. Pause the video, review the question, and then we will discuss. A 20-year-old man presents to the clinic after a week-long intravenous heroin binge because of constipation and abdominal fullness. The CT scan shows excess stool present in the colon and rectum. Heroin inhibits bowel motility and causes constipation by which of the following mechanisms? This is a good example of a question that contains a word that sometimes you're going to focus on so much that you convince yourself has to show up in the answer choice. And for me, that word is inhibits. The phrase that says heroin inhibits bowel motility sort of plants a seed in my mind that says my correct answer must have the word inhibit in it, and perhaps that led to you choosing choice A. But if you think about it, heroin is an opioid. In fact, it's a full mu agonist. How does heroin inhibit bowel motility? By stimulating an inhibitory receptor. The correct answer here is choice E, stimulation of mu receptors. Here's question number 2. Pause the video, and then we will review. A 30-year-old woman with a history of tonic-clonic seizures complains of double vision, thickened gums, and a growth of facial hair since starting a new medication. The mechanism of action of this drug is most similar to, well, obviously you have to decide what is the drug. Shouldn't have been the most difficult part of this. She's being treated for tonic-clonic seizures. Double vision, thickened gums, and growth of facial hair says this must be phenytoin. So the question becomes, how does phenytoin work? Perhaps you remember this drug is a sodium channel blocker. But then you had to take that mechanism and match it up with the options that are given here. Sodium channel blockers are also called class 1 antiarrhythmics. We covered that back in our cardiovascular section. Phenytoin, in fact, can be considered a class 1B antiarrhythmic. It's in the same category as lidocaine as a sodium channel blocker. Here's question number 3. Review the question, pause the video, we will discuss. A 26-year-old woman undergoing surgery is given an inhalant anesthetic. She is also given an IV dose of succinylcholine. Within minutes, she develops increasing core body temperature and muscle rigidity. We want to know the mechanism of action of the preferred drug to treat this patient's condition. First of all, what's the condition? This, of course, is malignant hyperthermia. She was given succinylcholine. She gets an increased temperature and muscle rigidity, classic features of malignant hyperthermia. You have to think about what drug treats that condition. That would be the drug dantrolene. And then we have to figure out, how does dantrolene work? How does dantrolene cool this patient down? It interferes with the release of calcium from the SR. The correct answer is choice A. This is question 4. Pause the video, review the question on your own, and then we will discuss. A 22-year-old patient was given a bolus of a drug for muscle relaxation. The patient should have recovered within 10 minutes, but instead required mechanical ventilation for 8 hours. The most likely explanation is the patient was deficient in what? Well, think about the drug. Given a drug for muscle relaxation and should have recovered very quickly, perhaps this is the drug succinylcholine. But the patient did not recover quickly because they were deficient in pseudocholinesterase. Choice E, that's the enzyme that metabolizes succinylcholine, giving it a short half-life.